Management of the airway is paramount to safe perioperative care. Difficult and failed airway management accounts for 2.3% to 16.6% of anesthetic deaths, and the following steps become necessary to favorably affect the outcome. Intubation is one component of the spectrum of emergency airway interventions. Proper preparation is key to successful intubation. These are the things needed at the bedside before beginning intubation. Before proceeding with intubation, assess all available clinical information, including the patient's suspected condition, history, anatomy, physiology, and goals of care. Raise the height of the bed to allow comfortable assessment of the airway by the provider. Align the ear canal with the sternum ledge. Place the patient in a sniffing position by slightly extending the neck. Pre-oxygenation displaces nitrogen from the alveoli, creating a potential oxygen reservoir that may prevent hypoxia and hypoxemia during apnea. Begin pre-oxygenation as soon as possible before intubation, even for patients with no apparent hypoxia or hypoxemia. Administer 100% oxygen for at least 3 minutes using a non-rebreather mask supplied with at least 15 liters per minute of oxygen. While the patient is pre-oxygenating, it's a great time to do an equipment check. First, see if your laryngoscope is functioning, and go to each other equipment to make sure that it's there and to make sure that it's working. Check the cuff of your ET tube if it's functioning. Check if your ambu bag is working and it's attached to the oxygen supply. With your left hand, hold the laryngoscope at the base, where the blade inserts to the handle. With your right hand, use a scissor motion to open the mouth and facilitate the laryngoscope passage by pressing caudally on the patient's lower incisors with the operator's thumb and cranially on the patient's upper incisors with the operator's index finger. Insert the blade into the right corner of the patient's mouth. Use the vertical flange of the Macintosh blade to push the tongue towards the left side of the oropharynx. Visualize and lift the epiglottis. Visualize the vocal cords. The tube is inserted beginning at the right corner of the mouth. Primary placement is confirmed when the tube is visualized, passing through the vocal cords. When correctly positioned, the tip of the tube is halfway between the vocal cords and the carina. Correct tube placement is a minimum of 2 cm above the carina. So this is approximately 23 cm at the incisors in men and 21 cm in women. Remove the blade. Hold the ET tube against the teeth with your hand while you remove the rigid stylet. At this time, your colleague will inflate the balloon. If an end-tidal CO2 is available, you may attach it now. If none, connect the tube to the ambu bag. Confirm that the ET tube is in the airway. You can check for color change in the end-tidal CO2, or you can auscultate for the bilateral lung sounds in the axilla or the epigastrium. This is to confirm that what you are hearing are breath sounds over the lungs and not over the stomach. Once you have confirmed that the tube is in the airway, you can now focus on securing the tube with tape, getting post-intubation x-rays, or connect the patient to a ventilator machine, or continuous ambu bagging if none is available.